feel that comfortability. Now leg like this. Get 2 pillows, please.
ساعده يعني. انتين. اثنتين جاب ثلاث يتعلمون
كرم حتى القاضي لا قصر. Now, can you take your legs up? Give me one.
Now keep
your legs. Relax.
مرتاح. أزين من قبل.
Are you comfortable?
تبي مسج؟
أنت لا.
Yeah.
This is called line, doctor.
You have to think it. Suppose you have your own brains. Please use
Okay,
your
but it's.
This
I'm
is
asking you to use your
crocodile.
own brain. I'm not using anything of my own. It's not in the book. I know this will be the comfortable position. Yes or no? Yes. The legs are not straight. Aram say
Okay.
Now,
Side.
questions on this? This okay?
Yeah.
Turn this hand.
And this hand.
This hand is okay. You want to keep it up, keep it side, anyways.
Not comfortable. Yes.
No, here it's not comfortable. That's what. You can keep it up, and you can keep it here, and then sleep.
والله لازم نجرب في البيت.
You want one more pillow? Take one more pillow.
No.
يعني أهم شيء يكون مرتاح.
Why you want to keep
لا
that?
مو لزوم. هذا ما تسوي اوكي.
Keep your legs side. Okay, then what?
1 كيلو كيف؟ جنب.
وين الحبيب؟ لا ما يصح. سلامات.
بحط له واحدة هنا. أنا ماسك بحط له واحدة.
اقول انقلع اقول.
It's okay. No, he say no.
يا حبيبي سوي انت. Fair play. واخر لا افس.
Let them play. One day I will.
هذا مو.
Let them play. Monday I will play. Why are
Okay,
you
this
bothered?
is right or wrong.
Okay.
آمنت بالله. يا كابتن.
Now, keeping like that, hands here. Okay, hands on this one position. If patient is comfortable with this, it's fine. Okay.
It's not.
If it's not, ask him a pillow over here.
شت جايب لي.
Ask him a pillow here.
Yeah.
If he's not, if he's comfortable, fine.
تبي مساعدة ولا مرتاح؟
No.
إيه، لا.
Guys, position and insertion of cuff.
What?
Medial epicondyle. Can I remove?
Tendon
Tendo achilis.
Achilles.
This one. This one. This is called as tendo achilis. Now these two muscles come here. The soleus get attached. This is tendo achilis get inserted at calcanea. Calcaneal tuberosity. Now, how to stretch that? How to stretch it? First step. First step of stretching is
يدخلها كلها.
my shirt. Now, what to do is first, I do like this, keep the knee in flexion, and I do a complete dorsiflexion. When I do a complete dorsiflexion, what muscle is stretched? Is it soleus is stretched or gastrocnemius is stretched?
Gastrocnemius. Both.
But soleus more than gastrocnemius.
Excellent. In this stretching, only soleus will stretch. Okay, in this stretching, only soleus will stretch. Now, this is dorsiflexion. Okay, I've kept this leg like this. Okay, I've kept the leg like this. Now, I don't change this position because my soleus is stretched. Okay, I don't change this position. Now I slowly
extend
go and
it.
extend the knee. When I go slowly go and extend the knee,
We'll stretch the gastrocnemius.
where is pain? No pain. Very now. Where is pain? Where is the pain? Pain is in the gastrocnemius. Why? Because the gastrocnemius is stretched, and this stretching is excellent. You can make the patient cry. You have to make the patient cry. You have to make the patient cry. If you don't make the patient cry, he can never walk.
So if I give him more this,
You think I cannot make him cry? Should I make him cry?
Yes, yes,
والله ما
yes,
يمشي.
yes. Yes, يلا.
Okay, if I show.
أنت مع بعض.
Huh? Good.
هي بيتسيو دكتور.
يلا يا عيال 10 ريال.
والله لا بتسيك يا عيل ابوي.
Understand this? Okay. Don't worry. No, it's good. Now, I will do his stretching. When he will walk, he will say it's very good. He feels good in.
In hamstring muscle.
As pain is felt in hamstring, you are feeling pain. He will not feel pain. If anyone is there, he will feel pain here. Where he will feel pain? In hamstring muscle.
Then slowly relax and back leg to the natural position.
Slowly I will sit and then relax the leg to the
Natural.
Once I take it up in the position of stretch, it will be 30 seconds. 3 times.
اقسم بالله انه ما يتعدى.
Is that easy?
Yeah, very easy.
Then
Repeat the procedure 3 times. That's all. This is for each one. There is a procedure like this.
30
يعني
seconds.
3 مرات تسويها. 3 times.
Is that easy?
Very easy.
3 times I will.
I want you to write all this on the book and do it on the practical. Your practical will be depressed.
كيف
يقول كيف تكتبونه في الكتاب
حلو
لو تكتبونه يعني في الدفتر حق
خلاص تحفظون.
شنو تعرفون هذا البروسيجر
دراسة كاملة
مو تحفظها تعرف شلون تسويها هذه الطريقة ايه افهمها واعرف شلون تطبقها
إذا فهمت الطريقة وعرفت كيف تطبقها.
خلاص يقول تصير حلك صحيح
طيب في
العملي
يسألك هذا أو كذا أو كذا.
Okay, but you will ask why, how, what.
I will ask why I should lock this knee. See, that is a procedure. How to do it? If you do that, I will give you 5 marks, full marks. But for next 5 marks, what do you do? You understand?
Yeah.
The procedure is 5 marks.
The next 5 marks is for talking, for answering
Yes,
some
the next
questions.
mark is reasoning for the procedure. There is something called as reasoning for the procedure. Why I do this? Why I told this? If I don't know what will happen, that will call as reasoning for the procedure. One is procedure, then reason. Yeah, procedure. The second one is reasoning for the procedure, which includes effects. Okay? So now, Abdulaziz, check with adductor. That is quadriceps, there will be adductor. Adductor.
Yeah, adductor muscle.
Adductor.
Okay, adductor muscles action, adduction of hip.
Adduction of hip. What is adduction of hip? Now I am in this position. This is adduction of hip, right? From here to here is
Adduction.
هايبر ادكشن.
hyperadduction. Okay, wait.
لا
Wait. What is adduction?
inside.
adduction inside.
Inside. Okay.
هايبر الدك.
Now I am in this position. I come back to this position. What is this?
Adduction. No adduction.
احنا عارفين انه زيرو بس وش هي؟
No movement, but there is some name. I told you this.
هايبر. Yes.
Okay, fine.
What is it?
I told you this.
Okay, tell us again.
Remember, what is this? What is this? If this is extension, what is this? Yes, faith. Faith, come on.
والله اني اعرف. هي هذه
طيب
فليكشن.
ندري انك
هذه فيها فليكشن بس مع اسم ثاني.
هذا
ري فليكشن. ريلاتيف.
Relative.
يس
Flexion.
relative flexion.
Flexion. Relative extension. Extension.
كذا
Relative is when you back to the natural
Back to the
position.
neutral position.
Okay.
Back to the anatomical position is relative. Now, same way. Now, what is okay? Leave that. Come back. Correction.
Okay. Adduction of hip.
So,
Adduction.
what is the opposite movement?
Do opposite movement of action. Adduction to abduction.
Abduction. Okay. Position patient. Next.
Position. Patient spine.
Patient supine.
Both hip knee 90 flexion. 90-degree flexion.
Both hip knee 90-degree flexion. Then.
Keep your hand. Keep the therapist's hand on medial aspect of both knees. Like that.
Medial. Aspect of both the knees. Then.
Okay. Ask the patient to do abduction of hip.
Okay. Now, in this, there is one point. Try to join the knee. Join the ankle. Ask the patient to join the ankle.
Then put your knees between them.
Yeah. Both the ankles. Now, ask the patient to do abduction. Do abduction. Take it back.
هو يبي يولد.
Okay. Now, ask the patient to do abduction.
Then give a procedure to increase abduction
Pressure.
pressure.
Now, I give pressure to abduction.
Causing stretching. Causing stretching.
Causing stitching. Now, ask the patient where do you have pain?
When?
Here. This is adductor muscle, guys. Ask him where's the pain. Where's the pain here?
Okay.
Where's adductor muscle? Understand this? If I do it for someone else, Abdul Aziz, if I do it,
Say Ibrahim.
he will cry.
Because it's very painful.
Usually, this muscle is tight for everyone.
حلو النظام يا اخي زكوا اليوم
But can I take this call, guys?
Yeah.
Stabilize the ankle here. Okay. And then take it.
Why?
Why? Anyone can answer why?
Why what?
To support to that the knees don't move, because if you don't support them, the range of motion would not be.
Something else.
Because the hip joints.
How can you change fertility? Okay, if I don't join? No, something else. Now, if I don't join, and if I don't be in this position,
You know this will be rotation here, and this will be stretch more.
something else.
Because the stretch at the same time.
No.
Stretch two muscles.
Now, you don't know the insertion of the muscle. Now, what happens is, if the patient, if I don't join the ankle and don't stand in this position, okay, what will happen is, as I am like this, if patient is tight, what will happen is, he will take his neck front.
Yes.
So you will lose the stretching.
As soon as his leg goes front, there will be relaxing.
So you
Then not will
So
be
you will not
the
be
stretching.
Cheating of the muscle. Yeah, you said cheating, right? Cheat.
So I did that. Like this and open.
Ask whose muscles are tight. Any other model? You cannot call him as a model.
توك صاحب تمدد الرداد.
He plays football.
مو هذا هذا.
No.
No.
He plays.
I don't even. He plays sleeping. Okay, no. Why I'm asking you is you can see that if you pull it like this leg will automatically go straight because of the pain. Now, this is one technique. The second technique is what you know. Ask one patient to keep the leg like this on the edge of the bed. Now this is straight. Okay, what I can do is I can hold it like this, hold it, and I can start pulling it.
This is also stretching.
Single muscle of this. Why? Because this knee is locked now. I cannot move. Right? This knee will not move. And then I can pull it for single side. Action is flexion, abduction,
and
external rotation of the hip joint. This is the action. Okay? Of this muscle. Like this. One is flexion, abduction, and external rotation. This is the movement. Now, what I will do?
Do adduction.
Do adduction,
extension and lateral rotation.
and internal,
Internal.
or medial. So, what is the patient position now?
Sideline.
Patient sideline. Patient position sideline. This.
Then completely flex the opposite leg.
Completely flex the opposite leg. Now, I want to treat this leg. This is the affected leg. So, what I do? This leg I will flex. There.
Now hold the affected leg, do hip extension, adduction and internal rotation.
Okay. Now, hold the affected leg. Okay. Hold the affected leg. Do extension.
Extension,
Okay. Then
adduction,
adduction.
وجه حمر
internal rotation.
Okay. Now, how can I do internal rotation? Only thing is it's easy. Okay. Now, I hold it like this. What I do? I do extension,
extension
adduction, and then how
External.
can I do internal rotation?
external internal
Just lift this.
Yes. أحد تطلع لي.
Come here, you cannot stand.
والله.
Are you all
Give up. أنا give up.
sit in one place do?
أنا give up.
أي تمشي دكتور أي تمشي دكتور أقول كفو
Ah, yes. Okay. See, if I hold like this, it's how it's easy. I'm holding it. I'm fixing my leg. So now, if I take for extension, he will not fall.
Yes.
Yes,
Yes. look at it.
he will not fall. Now, I take for extension. Now, what I do?
adduction
Adduction.
internal rotation
Internal rotation. How? I will just take this hand up.
Yes.
If I take the hand up, it is there. There is a pain.
Give up.
Where you have pain?
Give up.
Somewhere else.
Where?
He will have stretching here. But right now his muscles are paining somewhere else. Okay.
يقول هنا
South. Give your mobile here.
To increase shoulder external rotation, begin with the shoulder positioned in slight abduction or scaption. Flex the elbow to 90 degrees so the stretch force can be applied to the forearm. Stabilize the scapula at the anterior shoulder. To increase internal rotation, use the alternate hand placement demonstrated here. To increase flexion, stretch the shoulder extensors while stabilizing either the axillary border of the scapula or the superior aspect of the pelvis. Apply the stretch force to the distal humerus. To increase abduction, stabilize the axillary border of the scapula. To stretch shoulder flexors, you must place the patient in a position in which the shoulder may be extended past the zero position, either prone or with the shoulder over the edge of the treatment table. Stabilize the scapula with one hand and hyperextend the humerus to the end of its range. Stretching to increase elbow extension requires first stretching with the elbow in supination, neutral, and pronation. Then, after full elbow extension is attained, stretching the two-joint biceps brachii muscle across the shoulder and elbow simultaneously. Stabilize the anterior aspect of the shoulder and apply the stretch force at the distal forearm. When stretching the wrist, make sure you allow the fingers to move freely to ensure minimal restriction from the multi-joint extrinsic musculature that also crosses the wrist. Stabilize the distal forearm and apply the stretch force across the metacarpal region for extension, flexion, radial, and ulnar deviation. Individual wrist tendons can be isolated by aligning the stretch force with the particular tendon. The complex relationship among the joint structures, intrinsic muscles, and extrinsic musculotendinous units requires careful examination to determine what structures are restricting motion. Isolate each joint while applying the stretch force. Stretch extrinsic musculotendinous units across one joint at a time, starting with the most distal joint. When stretching the carpometacarpal joint of the thumb, apply the stretch force to the first metacarpal, not the phalanx. When stretching the hip, it is important to stabilize the pelvis. This may be effectively accomplished through positioning the opposite leg. To increase hip extension, flex the opposite hip. To increase hip flexion, extend the opposite leg. Apply the stretch force against the distal thigh. Note that to increase extension beyond 0 degrees when the patient is supine, the hip must be at the edge of the treatment table. With the patient prone, stretch the hip flexors to end range. The pelvis must be stabilized to avoid stress on the lumbar spine. With the patient prone, stretch the internal and external rotators with the hip in the extended position. Be very careful. Using the tibia as a lever places stress across the knee joint. A tight tensor fascia lata abducts the femur and rotates it internally, placing tension on the iliotibial band. This is a common cause of painful hip and knee syndromes. To stretch the hip abductors, position the patient on his or her side with the hip to be stretched uppermost. Flex the bottom hip and knee to provide stabilization and stabilize the pelvis. Position the hip for stretching by abducting it, then extend it and rotate it externally. Flex the knee to provide additional stretch, then lower the thigh, causing adduction. Hip abduction is increased by stabilizing the opposite leg and abducting the thigh. To minimize stress on the knee ligaments and capsule, make sure you apply the stretch force proximal to the knee. Perform internal and external rotation with the hip and knee positioned at 90-90. Use the leg to turn the femur, taking care to minimize stress on the knee. To attain terminal knee extension, place the patient in the supine position with a bolster or roll towel under the femur. Stabilize the femur and extend the knee by applying the stretch force against the distal leg. Once knee extension is attained, stretch the two joint hamstrings by maintaining the knee in extension and flexing the hip. Stretching the heel cord in order to increase dorsiflexion should be performed with the knee flexed and with it extended. Inversion and eversion of the calcaneus is important for mobility when walking on uneven ground. Individual musculotendinous units are stretched by aligning the force with the tendon insertion. The large toe must have extension for normal gait.
Can go up when the head of the humerus go down. Yes? When the head of the humerus can go down, that time this can go up. This is opposite. This is what is the rule. Now my capsule or some problem in the joint, this is tight here. Can my hand go up?
No. I do mobilization.
Actually, inside the joint it will go down.
Yes.
So I do like this.
This is what is orthokinematics. Inside the joint, it will go down because what surface is this? This surface is convex. So convex goes in one direction. The long axis goes in opposite direction. So now, if my head of the humerus is going down, then my hand is going up. Yes. Now patient tells you the problem is what? Patient says, doctor, I cannot take my hand up. So you know what?
It's inside the
Is inside the joint. What is not going? The head is not going
Yes.
down. The head is not going down. Patient doesn't know about this. But you know that why the hand is not going up? Because the arthrokinematics, the head is not going down. So what as a physiotherapist you will do? I will do a mobilization to push this down. I push this down, what will happen?
Move.
So without arthrokinematics, there is no osteokinematics.
So osteo is dead. Only arthro is good. Maybe having
Means osteokinematics depends on
the arthro.
the arthro. If no arthro, no osteo. Is it complicated?
No.
In any joint of our body, this will happen. In any joint range of a patient. In fact, close it. Now guys, what is this bone here?
Acromial.
Anterior
Anterior acromial process.
ايدك.
Acromial process is here.
واحد عنده فكر دولي.
What is this? Trying to move his head of the humerus downwards. Okay, I'm trying to move his head of the humerus downwards.
So,
Means what I'm doing, this is his, this one, glenoid cavity. This is his head of the humerus. This head of the humerus, this is flexion and extension, yes?
okay, yes.
But now what I'm doing a movement like this.
It means anterior.
Posterior slide.
Posterior.
نرجع ورا.
But from anterior.
If I want to push anterior, go posterior, where will I push?
But
Anterior. From anterior.
down.
Okay, now his position is here.
Okay.
His position is here. Okay, now I want to push this down. Because what is important? This movement of slide is important. If the humerus don't slide, if the humerus don't slide, what will happen? There will be no flexion. There will be no flexion. So what the technique of mobilization says is, what the technique of mobilization says is, now, if you see like this, I can feel over resistance, that there is, what you can feel now?
Resistance. It's slide.
One person keep a hand here, just keep
Go
a
down.
hand here,
Wait.
just keep it there, okay? What you can feel?
Down.
What, some hard part is coming
Yes.
down? Now, what he is feeling is his bone is coming down. His
This
bone
is
is
bone.
coming down. Can you feel anyone else? Bone which is going down. Now, this is what is called a slide. This is what is called a slide. Now, when I'm doing this, he's a normal patient. Okay, he's a normal person. When I can go down and when I feel that there's a movement. Okay, that is what it says tissue resistance. Okay, after this, now there are 4 stages. Stage 1, 2, 3, 4. After that, what is there is from tissue resistance to anatomical limit. There's a stretch.
More.
More. Now you keep the hand. First step.
More stretch, more pain.
It's more area.
Yeah, the
area down.
more coming down.
Yes.
See, what I'm doing is, see, now if this second finger is my limit, very softly, very gentle. Okay, this is grade 1 and 2. Means how if I show it in the body, in this part, see, if this point is there, okay, I'm pressing it down and relaxing. This is 1. There are 3 grades, there are 4 grades. Means just touch and go, touch and go, touch and go. Now, grade 2 is little more down, up, little more down, up, little more down, up. Grade 3 is I touch the position and then come back. I touch the anatomical position and then come back. And the grade 4 is like I completely leave the anatomical stretch limit and I go down. This is a stretching of the soft tissue, and that is why it is divided into grades.
So each time you have to push harder.
Each time you have to push harder.
Patient, he feel the pain.
If he has a problem in the shoulder, he will feel pain. If the patient has a problem. But now, this mobilization, if you do it, 100% recovery at 10 sittings. 10. Now, patient says, Nasir, take your hand till here.
Like this?
Oh, yeah. The patient is taking till hand till here, and he says, doctor, I cannot take more than this. Doctor says, I cannot, the patient says, doctor, I cannot take hand more than 60-degree angle. Now, means what? There is some problem in the rolling. There is some problem in the sliding. Now, when we use this mobilization technique, if exactly it is because of a capsule, okay, no other problem, only because of the capsule. Now, you do this mobilization, hold the clavicle, hold the scapula. I'm holding the clavicle and the scapula. Now, the clavicle is not moving, the scapula is not moving. Yes? Now, what do I palpate? What do I palpate? No, I palpate greater tuberosity. I palpate the greater tuberosity which is here. I put my hand, this hand over the greater tuberosity and push the head of the humerus downwards from the shoulder.
Sliding.
Yeah, sliding. I am doing a posterior slide. All the force is from the shoulder, not like this. All the force, if you see me,
I feel all the force on the bone.
yeah.
Exactly, there in one point.
Now, what I do, I don't push it like this. My force is not here. My force is coming from the shoulder.
Perpendicular.
What I do is, exactly I hold it here and I give it like this. Okay. As soon as you do a 10 movements like this, okay, relax, again do for 10 movements like this, 100% I bet you that his hand will come up till 70 degree. Take it up, take it up, take it up, his hand will come here.
After 10
After
minutes.
after 10 times.
In the same day.
So in
Same time. Movement.
Uh-huh.
The bone are not doing their function of rolling or sliding.
Because the capsule very tight, and I
So
do this
why
to
your
stretch the
movement-
capsule a little more.
why your movement
Open the
made
cups.
it, made it better?
تحياتي لك.
Why your
جالس
movement
أحسن.
made it better? Your movement, why
وش
made
شو
it
ما فهمت
Yeah.
هذا سر المهنة.
down? طيب
بص
Yeah, answer
حبابي.
the question.
طيب شو ذا؟
Slowly tell me what you tell me. What you tell
What
me.
the capsule is very tight, and it's don't let the bone to move.
It don't let
The joint to move.
it don't let the which movement.
محركة دي والساعة.
Slide.
It don't allow the arthrokinesis. Once the capsule is stretched, what will happen?
Available to move more.
In one time, can I treat him that?
100%.
One time.
One time.
اضغط له 10
There
مرات.
will be an improvement. No, I'm not telling you full.
If there is a problem in flexion,
there will be an improvement. 100%. There will
So we can do it for 3 or for 6 months.
Dr. Rashid, can I ask you a question? When someone raises his hand on a therapeutic, that means his muscles is working,
Yes.
his nerves is working.
Yes.
The problem in the joints.
Maybe.
So what
His muscle is weak. Maybe this also. His muscle is weak.
So we
So
need
how
to
can
do
I figure
MMT
out?
to make sure if MMT
When
5,
everything is over, when I come to know that the problem is only at the arthrokinematics,
hip joint.
understand this?
yeah.
So when you do that, this will be a stretching, and then when you do this, 100% there is. If you do it properly, minimum 10 degree of improvement you will see in one sitting. Minimum 10 degree. Maximum you can get anything. Once what had happened, I sat for a patient for 1.5 hours, do mobilization, and from 30 degree, 60 degree, he got it to 120 in one day.
Very good improvement.
He was like, I was suffering since 6 months. My hand was not going up. How did you do it in one day? Nothing. It's only anatomy and biomechanics. This is what is anatomy, it happens. I changed only the anatomical structure.
Man.
So now, understand this, guys? So some people say this. Now how mobilization is done? Okay, how they do? This is one technique, or else all the videos you will see like this. Now, take your come at the edge. They come at the edge. Okay, they support the thigh and the elbow. Okay, and they give a push. They hold at the upper end of the femur, upper end of the humerus. Okay, and then they push it down. This also.
نفس الشيء نازلة.
What happened?
Can I pay?
Please.
Here.
The first one is more clear because that is what is Maitland do.
The better technique.
The little upgraded technique.
So that's what.
But right now, if I start teaching you with the Maitland, you will be more confused. You will be more confused. Earlier batch, I have all taught Maitland. Everyone I taught Maitland. But they didn't understand it.
So you want to work with us grade by grade.
So I thought of teaching you only what is there in the videos. Yeah. Same way.
For extension.
I hold the patient relaxed.
This for what, doctor?
Extension.
Yeah.
Extension. Now I hold it. I take it and I then push it. The shoulders going down. And
You
then,
shouldn't put a towel under here.
if you want, you can put the towel. It's not
I think
necessary.
it's better so that the scapula doesn't move.
Sometimes they say that you have to put it, but some of the videos what you will learn is not there. It's only to keep in the abduction, okay, and then do.
And the upper end.
Just relax. Same. Is it paining, Abdullah? Then leave it. If it is paining, then don't do it.
يوجع كل ما يوجع.
Because
No, no,
night it will
no,
pain.
no pain.
If it is not paining now, then it's fine.
No
I show you the extension. All this videos.
And if you want adduction,
Now I want adduction. I want adduction. Where should be the movement? Up. What this is what is glide. This is glide. What is this part? If this is inferior, what is this? Superior. So I give superior glide for adduction. I give inferior glide for abduction. I give posterior glide for flexion. I give anterior glide for extension.
Yes. Clear.
Understand?
Yes.
always the opposite.
Why always the opposite? I will ask you. Why is
Because
that
the
there?
axis of
Because the
from this beginning.
Because of the concave convex rule. I hold. Now I want to do abduction adduction. Okay. Now what I do, I get it as up as possible. Okay. I come as up as possible. I hold. See what I'm doing. I'm holding here. I'm stabilizing at this point. I'm stabilizing the elbow with my wrist, and I'm holding the humerus. Then what I do, guys, if you're not interested, you can go home. No, sure, it's okay for me. You can go home, I'll give you the attendance.
No, very interesting.
But don't waste my energy.
Okay, for
Now,
what?
what I'm trying to do is, I'm trying to search. Now, this is what is this point? This is acromion process. Just below the acromion process, I keep my wedge.
Yeah.
This is my wedge.
Okay.
You know what is wedge, right? What? This is acromion process. Just below the acromion process, I keep my wedge.
Okay.
Okay? I keep my wedge here. I'm holding it here.
Push inferior.
Ask the patient as much as he can do abduction.
So,
The
after
patient
that?
can do. Now patient says I can do abduction this much. Okay.
Okay.
At this point, now I take my position. I take it here. From this hand, I push it down. Where is this movement? Where is the movement? Inferior. Down. Inferior. So if this is goes inferior, if the convex surface is going inferior, what about the long axis?
Anterior.
Long axis comes superior. Superior means what? Abduction. You understanding my point?
Yes.
Clear?
Make the head move to move this opposite.
Inferior.
Yeah.
If the head moves inferior,
Yes.
according to concave convex rule,
See.
this hand comes superior. Superior means the name of the movement is
Abduction.
abduction.
Okay. Clear.
One question.
Yes.
So because
When you
that.
have to do pushing inferior.
When I want to increase the abduction rate.
So until what he can do the abduction.
Yeah.
So after that he will doing the.
So my question will be straight. My question will say, do mobilization to increase abduction range.
Increase abduction.
Do mobilization to increase abduction range. Now you should think, to increase abduction range, which movement should go? Now this is abduction. Means this is going up. If this is going up, according to orthokinematics, this should go down.
Yes.
Why? Why? Because this is concave convex rule. What is concave convex rule? That if convex is moving downwards, the long axis goes opposite. This, your answer is ready in your brain.
Yes.
As soon as you read the question, it's easy. Come, hold it here, take it down, because this is an inferior guide, because you know the answer. You know the anatomy, you know the biomechanics, you know the movement. This is what I'm going to ask you the question. Why did you do this? Why is this position? Why is this support? No, I cannot do this. Can I do this?
No, because
No.
I cannot do this. So your position matters. If position matters, you hold it here, you hold it here. I take my position and I do inferior line. Just below the acromion. Okay? Now next, I want to do adduction. Now for adduction, what I do?
the movement inferior.
Do adduction.
pushing up.
Do adduction.
Here.
Do abduction.
Now, so do adduction. Now, adduction this goes. So where is the direction of the push?
Up.
Up or superior?
Superior.
So what I do, I hold it in this position, I put this. I put my hand in the axilla.
Adduction.
Put my hand in the axilla and do what guide? What is this?
Superior.
Superior. I put my hand in the axilla, I put a superior glide, and which movement I get?
Adduction.
I get adduction. Understand this, guys?
Yes.
So this is very simple.
Very simple. Don't learn that.
انت اهم واحد تفهم قاعد يطبق عليك.
Okay? Fine? Shoulder movement over?
But doctor, why
You need two ways to do adduction.
Why two ways? What is two ways?
First one, first the shoulder. Up.
That is abduction.
Adduction. Adduction just like this.
No, I pushed my hand here. I'm taking my hand like
First
this.
one like this. This adduction.
This is for adduction.
Yes.
Why adduction this?
Yes. Convex go up.
If you answer this,
okay. Doctor,
it's okay. For abduction, adduction doesn't make a difference. This only near for flexion and extension.
without
with the belt, without the support. They tied a belt here. Now, if you can do that. Tie a belt. Okay. Then what should she do? She hold it. She cups it like this, where exactly at the level of the crease. What then she did?
take up, pull it, no,
Yeah,
down.
First she pulled it down.
Yeah.
First she pulled it down. What did she do? What is the pulling of down from here? If I'm pull it down, what is this?
Biceps brachialis.
No.
The ligament.
No. Tell me the you're telling me the muscles and all. What is this movement called? If I take it down.
Muscle. Pulling. Contraction. Pulling. Contraction or tension. Wishing.
What do you do it taking it apart?
Traction.
Traction.
Traction. Yeah.
I do a very good. I do a traction force. So if you can, some people are thin. If I'm doing with Abdul Aziz, it's okay. I hold one hand here, and I pull it down. But now Ibrahim is good. His body is good. So what I have to do? I have to tie it here. Or else if you tie it, don't tie it, doesn't make a difference much. Grasp here, and give a traction. Give a traction. Now what traction I am giving it? I am holding it like that and I am giving it like this. I am giving it down. So what happens? I am giving a traction. Okay.
She just pulled like this.
Yes.
And the muscles. I see
The muscles, yeah, that is different.
like a slide.
Now, yeah, that is one traction she has given. The other is she has tied it here and she has pulled it up. So either you can do a traction upwards, and you can do a traction downwards.
You can do it without supporting it, okay?
It's okay. Means better if you have a support. Otherwise, it's okay.
Maybe
If
he
you don't.
moved.
Huh?
Maybe he moved.
Because
No,
you
he
feel that the shoulder removes.
Yes, shoulder is moving. See now, when I do a traction, the shoulder is moving.
It's
But
okay.
you are doing.
But I am doing it. I can do the traction. Can you feel a traction? I am doing it. You understand what I say?
Yes.
Okay. So now, what happens is, sometimes he is a normal, but patient, you know what will happen. It's good. Sometimes body helps you to stabilize. What happens? The patient who has a problem in elbow. What is the problem in elbow? Is he cannot do elbow flexion. That's the reason I am doing this mobilization. Yes, I take it, I move it. I take it, I give a traction, I move it. But what happens due to the pain, the patient will pull the shoulder up. Now pull the shoulder up. Due to pain,
If he have pain, he will.
yeah,
He'll try to resist.
he will try to resist. So automatically when he resists, the shoulder gets stabilized.
The shoulder will be stabilized.
Automatically. Not the shoulder with the humerus gets stabilized automatically because he has pain.
Yes.
Now, when I am pulling it like this, he has pain. So what will happen when the pain is there? What will body do? Body automatically pull it up. So I don't have to stabilize anything. Automatically it gets stabilized.
What can I do?
That's what, you don't have to stabilize.
Because يعني stabilize القلب والشوكة.
See, he is normal. That's why when I am pulling down,
He doesn't feel
Is
anything.
that fine?
he don't feel anything. His shoulder is coming down. But for patient when you do it, you will think how to stabilize. You don't have to stabilize. Body will automatically stabilize. You understand what I say?
I see.
So this is one traction. So traction, just fully support. This is traction downwards, okay, and then a movement. Okay. Traction downwards and a movement of flexion with the traction. Okay. So what is important is traction with flexion.
So not.
It's not only flexion. It's not only traction.
And
It is both. It is traction with flexion.
what if I did the traction and raise it up?
You can do that. The second step, that is the second technique. That is second technique. Now, stabilize your shoulder. Now this is traction and up and pulling up. So what they do, some people do it like this, traction with pull up. Traction with pull up.
And all of the
If you have
the level.
if you have practical here.
Huh?
If you have fracture here, it's like this.
Okay, your question is nice. This joint will be stiff after the fracture only. The patient has a fracture here. Okay, the patient has a fracture here. Okay, for 3 months. Okay, for 3 months he will be in a plaster like this. His fracture is healed, but he cannot do elbow flexion and extension because the joint becomes stiff. That time when I do it, he will tell you little pain. When I hold here, he will tell you little pain, but it's okay. I am talking. Let me talk. Okay, so when he has a fracture, what will happen is 3 months his hand is like this, his fracture will heal because with the plaster, that white color plaster is there, but his elbow flexion and extension will be stopped. So this is what the technique we do for this kind of a patient. Okay, do a traction. Okay, do a traction. But see, where I hold the radius, I hold the ulna, I hold both the bone. Both the bone, I do a traction, I do a flexion. Okay. Then if you can stabilize here, hold it, give a traction and take a glide upwards. So inferior glide, then superior glide. Can you feel a superior glide? Because the force is less. Now. Down, what will happen? Now here is the elbow. When I push it down, what will happen? This will go back.
Yes.
This will go back.
No.
A bit.
Yeah, a bit, yeah.
Okay. Now, when I go back and when I take it down, is it the same rule what we are applying?
Yeah. No.
لا مو نفس.
Is the same concave convex rule we are applying?
Yeah.
Yes. So what I do, in this point, I will push it down. When I push it down and when I take it down, push it posterior and take for extension. Can I do that?
Yes.
Is it the same rule I am applying?
Yes.
Flexion and movement. I'm giving a traction and then flexion. Now I am giving a compression and extension.
Yes.
Can I do that?
Yes, sir.
It's the same, right? Yes or no, guys?
Yes.
Understand this? So the technique which goes like this is I press it down and I go for extension. I pull it traction and go for
Flexion.
flexion.
Yes.
I'm not doing anything extra. I'm just applying what rule?
Yeah.
I'm applying a concave convex rule. That's all.
Yes.
I'm not doing anything from my brain. I'm not doing anything from the book. I want this movement. How this movement will come? The movement will come according to concave convex rule. That's all. Understand this? Come back. Go to the next joint.
Rest.
Come back to wrist. Okay. What about wrist? You want to see the video for the wrist?
Yes.
Okay. Now, what is the structure of the wrist? What is the surface of the wrist joint?
Suddenly.
The radial. Radial على الدولة complex.
Radius and ulna.
Complex. لا. Yes, concave. Concave.
Concave. Radius and ulna.
Concave.
Okay. If I take the wrist, okay. Now in the wrist, radius and ulna.
Okay.
I'm talking.
Okay. Yes, he's talking.
Concave.
Complex.
And what is this? Convex. So now, there's how many movements are there? For example, I will just take it. There's flexion, extension. What is this? Which is this diversion? What is radial deviation?
This is with the
Lateral and medial.
Radial division.
Okay, how do you say this is lateral and this?
No.
medial with
Medial with radius.
yeah.
Sure.
لا الله يجزاك
لا
خير.
اقرا كذا.
This was ulnar.
medial medial
Guys, don't get confused. Fix one point first. Which is one point fix?
دكتور
Fix with anatomical position.
هذا مكان غايب.
First, fix yourself in anatomical position.
Lateral.
Now talk.
دكتور
What is this?
لا
Lateral. Lateral means which side of the bone?
ulnar.
radial
Radial. Don't get confused. It's easy. Fix one point. I'm standing here. I go here. In anatomical position, this is on the radial side. So I go the lateral deviation, because lateral means go outside the body, or radial deviation. I come inside, ulnar deviation or medial deviation, because it comes inside the body. Okay. Now, so flexion, extension, lateral and medial diversion. Okay. So these are the movements. Fine. Any other movements?
No.
Fine. So now in this, what is the structure of the carpals? What is the surface of the carpals? Convex. What is the surface of the radius and ulnar?
Concave.
Concave.
It wasn't always one of them convex, the other is concave.
This has to. This is universal rule, not my rule. If two surface has to come together,
One of them.
one has to be a concave, the other has to be a convex. Okay? This is universal rule. You take it for anything. Your specs, your clothes, everything. You talk about anything, this is universal. Now, in this point, okay, in this point, what will I do? Fix the patient in anatomical position? Okay. Patient position, best is make the patient sit. Make the patient sit. Okay. Now, ask the patient to be in anatomical position. Okay. Now, what will the patient say? Patient will say, doctor, I have problem with flexion or I have in extension. Suppose a patient says, I have problem in flexion. So, what will I stabilize first?
Radius,
Perfect. His lower end of radius and ulna. Now, see, now if I take this is the crease, right? What will happen is, if I take the styloid bone, there are two bones here. One is radial styloid here, one is ulnar styloid here. Yes? So what I do is, I keep my fingers like this.
just beneath them.
Just on above them. So this is, see, you go down, this is radial styloid, okay? This go down, this is radial styloid. So what I do, I keep my hand like this. So as soon as I hold my hand like this, what I am compressing and what I am holding here?
End of the ligament. End of the bone.
End of the bones. I am holding the inferior radio-ulnar joint. Yes, I am holding it. Now, as soon as I hold this, the next is my carpal. The next is my carpal. Okay, now, patient says, I have problem in flexion. I have problem in flexion. So, tell me, where should be the glide and where should be the movement? Think. Use the rule.
Do
Glide.
flexion and
السحب وين بيصير لما؟ حركة.
like elbow. You have to flexion and upward.
Like shoulder.
Down.
Shoulder, what will you do?
push it
Push it down. ما في push. Pull.
Shoulder.
Push it down.
Shoulder.
push it down. يا موسى push it down. دكتور push it down. لا
Shoulder.
like
Like shoulder. Shoulder, guys. Faith, check the shoulder video.
when I do flexion this
What did I do? To get
Interior.
anterior or flexion. Okay, now, what is next? Opposite. I make my hand prone. I do it. Now, which is this glide?
And posterior. No.
Anterior.
Yeah. To get a
Anterior
posterior
glide.
movement.
To get a posterior movement, or I get an extension. It's, see, I am giving an idea of posterior movement.
the same technique.
But it's not posterior movement, it's called extension. Only thing is to make acts opposite, I'm explaining it. So I give an anterior glide. Which glide is this?
Anterior.
I give an anterior glide, and which is the movement?
Extension.
Extension. Understand? Now, what will happen to the radius and ulnar? What about the deviation?
Like this.
Yeah, David.
Like this.
Now, I keep my hand in a neutral position. I stabilize the same way. Okay. Now, if I want more of ulnar deviation, I want to increase ulnar deviation, which side the slide should be?
Side the radius.
The medium.
To radius.
The medium. No.
Lateral. The radial. Because I want increase in this range. The patient has problem in this range.
كده.
So if I want increase in this range, where the glide should go?
Right. The opposite.
The opposite. The glide should go lateral, or the glide should go radial. So what I do, I stabilize here, I keep my cusp here, I push it laterally. When I push it laterally, or when I push it radially, which side is the deviation? The deviation or the increase in the movement is
To the ulnar.
to the ulnar side or to the medial side. Opposite, same way. I hold it here. I want an increase in radial deviation. So which side should be the movement?
Lateral.
Ulnar side or
Medial.
medial side. So I stabilize here, I hold it here, and I push it from this cusp. I push it on the medial side. When I push it on the medial side or when I push it on the radial side, which movement is increased?
His radial deviation.
Increased radial deviation.
How many times?
The head of the femur is convex. So
you will do concave movement. The concave will move.
why concave will move? The head of the humerus is convex. The head of the femur.
Stretch opposite
Down or posterior? Down or posterior? Losing in the joint, or you can say posterior. Now, I make this patient, now he is supine. Okay. Which bone I should feel?
Greater trochanter.
Greater trochanter. Okay, you know how to feel greater trochanter?
Yes. Lateral rotation. External rotation.
2 inch.
this. Then go down
2 inch. Now, from ASIS, I go 2 inches posterior. I go 2 inches posterior, and from this point I go 2 inches inferior. And when I go 2 inches posterior, 2 inches inferior, I do an abduction adduction, or I do an internal rotation and external rotation. I can feel the bone. Now I have felt this bone. Now what I do? I ask the patient to go sideline. Can you go sideline? Ask the patient to go sideline. Okay. Ask the patient to go sideline. Now, what you do? Hold. Now this is the greater trochanter. I fix my joint. What I do? I fix what? Fix the pelvic completely. Ibrahim, come back. More back. Oh. No. I have a cut here. Not paper. I will not tell you. Not black. Okay, I was helping my wife in washing the vessels. Happy? Which you will never do in your life, no? Now, this is the greater trochanter. Now, what I do? I stabilize the pelvic. I stabilize the pelvic. How do I stabilize the pelvic? I stabilize the pelvic by catching the crest on ASIS. Then what I do? I hold this and I give a push anterior. If I give a push, this is anterior to the body.
Yeah.
If I push it anterior, what is the improvement? Which movement will I get? Extension. Now, the pain. Okay. My question was flexion, right? My question. Okay. A bit off. Okay. Easy. Come here. Okay. Stabilize the pelvic. Okay. Stabilize the pelvic. Okay. Completely. Hold the greater trochanter. Now this is the greater trochanter. Yeah. I stabilize the pelvic. Hold the greater trochanter and give a push like this. When do I push? I give a push posterior. When I hold that and give a push posterior, what happens?
It goes to flexion.
It goes posterior. So which movement I get in the leg? I get anterior movement or I get flexion. Why? Why?
It's opposite move.
Because according to the concave convex rule, if convex surface moves in one direction, the long axis moves in opposite direction. Yes. So now this is a convex surface. Now convex surface is moving in a posterior direction. So the long axis comes in anterior direction. So this anterior direction is nothing but flexion of the leg. Yes. The same way, opposite, what I do is, I stabilize the pelvic. I stabilize, this is the ESIS, this is the complete test. I stabilize it. You either stabilize like this, you stabilize like this, or you take a belt. You have seen some of the videos. They put a belt.
Yeah.
You can take a belt also. Anything is okay. Now, after that, palpate the greater trochanter. Okay. How do you palpate the greater trochanter? ESIS 2 inch inferior, 2 inch posterior, 2 inch inferior. Yes. You palpate the greater trochanter. Keep your palm on that, and then give a anterior push. When you give an anterior push, what do you feel?
Yeah.
Now what is this?
Oh,
No, it's okay. Do you feel this?
Yes, I feel this. No.
You will not. No. You're feeling any movement here? What do you feel here? You will feel it. What do you feel? Come.
Wi-Fi feel.
Wi-Fi feel. After marriage also you do that same thing. Wi-Fi feel only.
انتبه كذا ولا شيء.
Yes, no?
انا عارف شو يقول بس ما يعني ترجم شيء.
أزين.
Okay. Understand this? So, go this anterior push. The convex surface moves anterior. The long axis moves in the opposite direction. That is posterior or extension.
So it's a bit in one time. We'll have
of the knee joint.
Inside convex, outside concave.
Tibia.
What is it?
Tibia concave.
Moving.
Femur convex.
What is inside and outside?
Moving.
Your brain is not femur convex, tibia,
Tibia fibula.
tibia fibula concave. But fibula doesn't come into play because it's only tibia which is there. Now, tibia is concave, femur is convex. Now, I have to do a mobilization. Patient comes to me, doctor, my knee is straight. I can do flexion, but I have to walk like this. He cannot do flexion of the knee. He is walking like this. He can do flexion. Now, but I have to do flexion. If I have to do flexion, what will happen? My leg has to come in this way. Flexion, leg up, and then go down. Yes? So which bone is moving and which bone is fixed?
tibia movement.
Okay guys, wait. Again, I walk. Okay? I'm walking very slowly. Check my right leg, okay? Check my right leg. I'm going like this.
One of them begins, then the other.
Can you explain it more better?
When you do flexion of hips,
في حركتين.
Who is fixed? Who is moving? Who is stable? Who is moving?
When you put it up, that
No, the opposite.
one and one.
The opposite. When you
One work, one stop, one work, one stop.
Yes. How? That's what. Excellent. How?
it's down. Tibia extension.
What is tibia? Fixed or moving?
when you move at first, the tibia moves.
First,
Yes.
Then
First.
the femur finish.
Yes. Now, at this point, from when I start from here, tibia is femur fixed, tibia is moving. I go down. As soon as I touch my leg down,
yeah.
who gets fixed?
Tibia.
Tibia gets fixed and then femur starts moving. Yes? Femur moves on tibia and initially the tibia moves on femur. Yes? Understand this? Yes or no? Now, when I want to do a mobilization, which of the bone is free to move? Is femur free to move or tibia free to move?
Tibia. Tibia.
Free to move.
Tibia. Tibia.
No, which
لا،
bone
بس
is
وش-
free to move? Which bone I can move?
الحين انت بتحرك وش؟
At first.
No, at first femur.
لا تبيا.
No, that is while walking.
The convex.
Now, when you are not doing anything, I want to do mobilization. Which bone is free to move? Which bone?
تبيا.
I'm going to use both. Tibia. Both? No. Which bone? I'm going to, yeah. Now what I'm going to do is, moving femur is difficult. Why?
Because you need thickness in the long way.
Because I need some movement of the long axis. If I move femur,
If you want to do flexion, you have to do.
this should go for extension, yes? If I want to move this bone, if I want to move this surface, what will happen to the long axis? It should move in opposite direction. Can I move it? So which bone I will move?
Tibia.
I'll move tibia. Come. Now, how will I do this? How will I do this? Patient comes to you. Okay, can you take this one? But now guys, he is in patella. Now this is the patella. What is this bone? What is this point?
Tibia kiss.
Something else.
Head of tibia.
Something else.
Head of
Tibia.
Tibial tuberosity. Okay, this is tibial tuberosity. Okay, where is that? Where is tibial tuberosity there?
Below the patella.
ارفع الصابونة.
Down patella.
Show me.
تحت الصابونة على طول. ايه البارد. هذا البارد.
That is tibial tuberosity. Now, this is tibial tuberosity, the one point. Okay. Now this is tibial condyle. Okay. Now what is tibial condyle? What surface is the tibial condyle? Concave. Now what is this condyle? Convex. Now, what I have to do? Now patient says I have problem in flexion. Okay. I have problem in flexion.
Concave.
Now, pull. Now this patient, I need to has a problem in flexion. I need to increase his flexion. So where should be the glide?
It will be in the same side.
In the
Same side.
same side?
Yes.
Sure.
Yeah. Concave.
Why?
Concave.
Because during
Concave.
depending on the
Axis
convex,
with
when it's concave, that the movable with the same it will in the same direction.
Perfect. So now I want flexion. Okay. Now this is what direction of the body? This is posterior to the body. This is flexion. Okay. But which direction of the body? Posterior. Now what should I do the glide? Which glide should I do? I should do a
Same side.
posterior.
النية يا أخي
Ibrahim, what is
extension
the-
ولا انتير؟
You want extension, so pull this.
I don't want extension, now I'm doing flexion.
Yeah.
So, how will I do? How will I do? I palpate the tibial tuberosity. I keep my hand on the not epicondyle, condyle of the tibia, and then what I do? I stabilize this. I stabilize the femur. I stabilize the tibia. I stabilize the tibia is not moving, the femur is fixed. Now where I am doing? Now I am giving a push. How do I push? I push the tibial tuberosity. Push the tibial tuberosity in which direction? In posterior direction. When I push the tibial tuberosity in posterior direction, what movement I get? I get flexion.
Okay, what you want extension?
Now you want extension. Now what do extension? Pull. No opposite.
Yeah.
Now what I do? I fix my hand, I fix my condyle here, then what I do? I pull it from my fingers. I pull it anterior. Ask the patient to sit straight or put a belt or fix it here. Ask the patient don't move. Now what I do? Fix the belt. See, now I am pulling. What is happening to you? You are coming front, right? So there is no stability.
Here and pull.
Not like this.
This is what? If I push it, it goes where?
No. Push the femur.
Femur. Why should I push the femur? How can I push the femur? Femur is fixed now. I'm not moving the femur. Because if I have to move femur surface is convex. If I move this convex, I should get the movement here. But this is locked here. I cannot do anything at the hip joint. Yes?
Yes.
Yes or no, guys?
Yes.
So I'm moving whatever movement I want. I'm doing a movement at the tibia. Okay. So if I want to increase the flexion range, what I do? I push the tibia posterior because according to concave convex rule, tibia surface is concave. What does rule says is the concave surface moves in one direction. The long axis also moves in the same direction. That's why now if I want to increase the posterior, if I want to increase the flexion range, I give a posterior glide. The posterior glide increases flexion range. Just keeping. It doesn't make a difference. The patient is stable. He is comfortable keeping the leg up, he is keeping it up.
He has different needs, but he can even keep it.
Now what can happen? No, do it. It's usually rare that the Now, what is the surface of the ankle?
Concave.
What are the joints in the ankle?
End of tibia and fibula.
Ankle
Concave. Concave, end of tibia and fibula.
No. Tibia.
Head.
Tibia concave.
End.
Ankle convex.
Check that.
Convex.
The metatarsal convex.
Not metatarsal. What is that bone? What is that bone? That is convex, concave.
Concave.
What is that convex bone? What is that bone? What is the name of the bone? Yes.
Tarsal.
What is that bone?
كفويد.
From teeth.
وش
تي لا تي تارسل
Tarsal, use something else. I'll make you cry.
Temporalis.
Please don't use your anatomy. That is talus.
Talus.
Tarsal and talus. They are two different things.
Talus, yeah.
Abdul Aziz? Okay. Now, you have a cup here. Guys, okay. Keep the hand like this. There. Yeah, that too. The medial malleoli and the lateral malleoli. Okay, the medial malleoli and the lateral malleoli, they make a cup. They make a cup there. This is what surface?
Concave.
Concave. Now, in between them, one sits. Who sits here?
Talus.
Talus. Okay, that is convex. Now, when I am moving, can I move the tibia or can I move the talus?
Talus.
Which is easy?
Talus.
Talus. So, now, I want to increase, what is this movement? What is this going up? What is this? Plantar. Now, if I want to increase dorsiflexion range, which side should the talus go?
Posterior.
Why?
Because
Convex.
What is the rule?
if the movement
Opposite direction.
in the concave, the longitude, the
Long
is opposite.
So, now what I do? I fix the talus, I fix the medial and the lateral malleoli, After fixing the medial and the lateral malleoli, exactly at the center of the two malleoli is the bone called as talus. Now I hold the talus, I fix this point and push it. Which side is this?
Posterior.
This is posterior. Now if this goes posterior, what will happen to this part? This comes anterior or dorsiflexion. Understand this? Fixing this point, I push it posterior, I push the talus posterior. Once I push the, why I am pushing the talus posterior? Because my ankle is out of the bed, at the edge of the bed. I cannot do this here. Go back.
MashaAllah.
I cannot do this. Right? This is wrong. What I have to do? I have to take it down at the edge of the bed. The calcaneum is at the edge of the bed. Then I stabilize the medial and the lateral malleoli, and after that I push it posterior. Now, if I want plantar flexion, now go prone. Now go prone. Now come down, Now I hold it. I hold the medial malleoli. I hold the lateral malleoli. Then I take the pressure of the calcaneus and I push it posterior, anterior. Means anterior to the body. I push it down. Anterior to the body. But what is that? Direction is downwards. But it is anterior to the body. When it is anterior to the body, goes anterior to the body. Which range of motion is increased? Plantar flexion. Understand this? Any doubt? So hip, knee, ankle. Ankle, any doubt?
اجمع كل المقاطع اللي عندك ونزلها في يوتيوب كامل.
اوكي.
Any doubt, guys? You position the patient. Okay. Once you position the patient, I will ask you what is this position, what is the derived position
Okay.
of that. Okay. Then coming to range of motions. Okay. Range of motions, I will ask you all the three.
Passive, active,
active assisted, and free. And free. When you do this movement, okay, I will ask, then in this I will ask you isometric, isotonic, eccentric. Right? This is one part. Range of motion is finished. Then coming to stretching. I will give you one muscle name. Do stretching for quadriceps. Position the patient, do it. Fine. Why you do this? I will ask you. Why this position? Now I say you hamstring. Okay? I say you hamstring. You do take the leg up and hamstring. I will ask you, why did you do this? I will ask you a question. Why did you do this? What you will answer?
hamstring.
For hamstring, the patient sleeps supine.
Yes.
I will take the leg on my shoulder. Slowly I will go up.
Yes. Stretching.
I will
To stretch
hamstring.
more.
Why you will do this movement?
To stretch more.
For complete stretching.
Do the opposite movement of the. What is the movement of the hamstring?
Flexion of
Extension.
flexion, extension.
So what I will do?
What?
I didn't say that I will do. Yeah. Please come. Please tell me I will put +1 in your sheet.
So I ask
Here.
you the question.
Now.
Tell me now.
Once we finish the lecture.
Our mark, we want to.
Which one? I will correct your paper first. Let me correct your paper.
Okay, teacher, continue.
إن شاء الله على النهاية إن شاء الله.
Understand this?
Mobilization.
Mobilization is same. Position of the patient.
Last thing,
What you ask?
mobilization. Stretching, then mobilization.
Understand this?
Just tool.
كيف تفعل